I'll probably interchange saying lipedema and lipedema during this presentation. I always do. The main problem we have is lack of awareness in the community. So I absolutely love giving these and telling my patients that more health professionals in Australia actually know that lipedema exists. So this is going to be a whistle-stop tour in the basics for health professionals, and I understand we've got allied health professionals and registered nurses, a lymphedema therapist and GPs listening to me tonight, which is wonderful. For the lymphedema therapist, you might find this a bit basic on the treatment side, but hopefully you'll get something out of the genetics and the really hot off the press information that I'm going to give you tonight. As I was lucky enough to be in the Northern Hemisphere and be able to live stream into the Fat Disorders Research Foundation conference, and there was some really mind-blowing things going on from that, so I'm going to let you know all about that tonight. So what are we going to learn tonight? Hopefully you're going to know about the pathogenesis of lipedema, that it actually exists and what it is, and to be able to differentially diagnose this condition from obesity and other metabolic disorders which cause fat in the body. And I'm going to give you an overview of what I do on a daily basis, the therapy for lipedema as a lymphatic therapist, and also give you a little bit of understanding about the surgery which is going on here in Australia. So if people come and ask you about this, you've got some knowledge to be able to say what's happening and how to get more information. So the first thing that many people say when I say lipedema, or patients mention that to their GPs, they'll say, no, you're wrong, you mean lymphedema. And that really angers patients because they say, no, actually I don't. And most people don't even know that lipedema exists. It's a fairly modern syndrome. It was first described by the classic trio Wold, Allenden, Hines back in '49. They work in the Mayo Clinic as a chronic progressive disease that gives a disproportionate body shape. So basically women come in with symmetrical increased columnar legs, and it's fatty changes in their legs. And these are the women you see walking down the street who've got enormous bottoms and legs, but they're incredibly tiny on the top. So it doesn't always look like obesity straight away. The extremities are unaffected. So these women do not have swollen hands or feet, unlike lymphedema, unless they've got really advanced lipedema, which we're going to talk about the stages in a minute. If they get stage 4 late stage, they can get swollen hands and feet, but normally the hands and feet are completely normal. So these are some of my patients I'm seeing at the moment. They've very kindly let me use their pictures. So it comes in all shapes and sizes, but generally what you see is the fat on the legs has a special lumpy nodular texture. And you can see all of those women have some sort of columnar legs with cuffing at the ankle, normal feet apart from the lady on the top left who has got a little bit of foot involvement because she's late stage, but all have got really normal feet. This, and I'm going to talk about SAT a lot, which is subcutaneous adipose tissue. The SAT is really persistent and it resists any form of exercise and diet. They'll lose weight on the top half of their body, but not the legs, and it's painful. So they'll talk about their legs are painful, achy, and obviously pain's a very subjective thing. Some people talk about really sensitive legs, some talk about actual pain, some talk about discomfort, but especially sensitive legs to pressure. And the question I normally say is, would it hurt if a cat walked over your lap? And they'll say, oh, agony, terrible, to that sort of thing. They bruise very, very easily if they bump into anything. These women bruise like peaches. And they also have spontaneous bruising, ecchymosis, where they'll say, I bruise for no reason whatsoever. The skin on the affected areas is quite cool compared to the upper limbs or the torso. And they'll complain about some fluctuation, either bloating or swelling, when they're sitting still, standing still, or in hot weather. So that's very pertinent to you guys in North Queensland, where it's really hot and humid. These ladies cannot tolerate this very well at all. And generally the swelling they've got is a non-pitting variety. So when we talk about pitting, we talk about pressing the fingers into the tissue, which is easier said than done with these ladies when they're tender. But I tend to do that on the pre-tibial area for 30 seconds. And they're generally a doughy feel to the tissue, a nodular doughy feel. There's no pitting there. But pitting, if they're like the lady on the top left with later stage disease, what we call lymphoedema, they can get a little pitting at the bottom of their legs with lymphoedema. And they have a very classic history. They all talk about normal legs until puberty, and some of them in pregnancy, so with a hormonal fluctuation. And then at that time they noticed the legs thickened up, and a lot of them will say, I got cankles after my period started. And they all talk about this sport, calorie restriction, exercise, or if they've actually gone on and had gastric bypass, they'll lose weight with the top half of the body, but not the bottom half. And we also see little exacerbations of this tissue growth with any hormonal fluctuations and gynae procedure. So very classic history they'll talk about. It comes in various stages. So on the right is an absolutely beautiful picture that Lipoedema Australia did. Very brave ladies, got their legs out to show the world it's different. You can all see the nodularity on their legs. So stage 1, the lady with the purple hair, third along, has got a stage 1 disease where it's a bit smoother. We've got some stage 2 ladies, and the ladies on the far right are up at stage 3 and 4. Okay. So it gets bigger and bigger, and you get more folds and walnut size masses, lipomas within the fat as it develops. That's the stages. The types are actually over on the left. So some ladies just have type 1, it's more like the saddlebags. The next type, type 2, goes down to the knees. The classic Wold-Elland and Hines type is the type 3 in the middle, where very thin upper body and both legs with cuffing down at the ankles. In type 4, the arms are involved as well, and 60% of Lipoedema ladies have type 4. You can see that quite a few of the women on the picture of the right have the classic bulge on the upper arms that's nodular. And type 5's the rarest type. I've only got one of these ladies with type 5 in my caseload, where it's from the knees down only. It's a genetic problem, okay? We know that because it's predominantly in women. There's only 8 case reports in the world of men, and that's on a background of hormonal imbalance. And we know it's an estrogen-related and polygenetic disease. A lot of people say, oh, they're looking for the gene. Well, we're not looking for one gene. We already know it's a polygenetic disease, and I'm going to talk about the genes in a minute. And these genes cause pathology within the vascular system, which then impacts on the lymphatic system. And we know that estrogen has a direct effect on the white fat through its estrogen receptors, and that's how this affects women. But unfortunately, we're not sure about the exact change yet in the receptors. There's a lot of research going on into this at the moment. So this change in the estrogen receptors in the fat actually causes the adipocytes to proliferate in a crazy manner, and they also get bigger, the hypertrophy, and they're very inflamed. They look completely different to normal fat, which I'm going to show you in one of the next slides. But we have in the FDRS presentation this year, they actually think that it's an estrogen-driven dysregulated angiogenesis, so very leaky, fragile vessels in the tissue. This vascular leak actually causes then changes in the fatty tissue. What we do know that 2 of the main mutations are actually mutations we see in primary lymphedema. So primary lymphedema is when people are born with lymphedema, or they've inherited it and it develops a little bit more later in life. And these people tend to have the vasculoendothelial growth factor 3 and a PIT1 mutation. So Shavitz actually found that some of the mutations genetically are very similar to some of the primary lymphedema that we know about. And here's a quick slide to show you that if you look on the right hand side where the arrow is, that the lipedema profile in that candidate 1 is very, very different to a lymphedema 1 that you see underneath. So we know it's completely different from lymphedema, and that's the beautiful work that Echo Boutte is doing. I must acknowledge her for that slide. She's doing this work in America at the moment. Amazing woman. So busy slide, but basically I want you to take two things away from this. Bottom right, you can see that Jan Clementidis's work, he's found that the genes are from three major parts in the body, that they affect the subcutaneous adipose tissue, the vascular system, tibial arterial system, but very interestingly, a lot of the genes are related to thyroid, and I'm going to come back to this later. On the top left slide, what I really want to show you is the red parts, which I've added. We know some of the genes are involved in lipid metabolism, insulin signaling, angiogenesis, and waist-hip ratio. And also in actin formation in the muscles, which is really interesting. Dutch studies actually found that obese people get stronger lugging the weight around, but lipedema women actually have much less muscle mass and strength. And there's definitely a problem with the actin formation genetically, which has been a really interesting development to try and work out why these women are weaker. And Jan Clementidis thinks there's hundreds of genes involved, a 10% prevalence within our female people on the planet, and that there are many different phenotypes of lipedema. So those types that we saw in the pictures, Jan Clementidis agrees that it's not just the original Wold, Alland and Hines type, but we're going to see different presentations of lipedema. Now, there's some work going on down the road from me in Melbourne, Tara Carnesis's lab at the O'Brien Institute, and she has actually found that adipogenesis in lipedema patients, adipose-derived stem cells are much more potent compared to obese people. So the obese adipose-derived stem cells, and these stem cells proliferate really, really fast. So that's the picture of it. The normal fat's at the bottom, the proliferation, but you can see on the top that those just adipose stem cells go absolutely nuts, crazy development for that hyperproliferation. And you can see the blue on the right there. The blue lines are the obese patients' proliferation compared to the lipedema patients, so it's totally different. So we can say that lipedema fat is definitely different from obese fat. That's what it looks like under the microscope. This is the classic picture that everybody shows when we talk about lipedema. Suga's study of 2009. The lipedema biopsy on the left was taken from a medial knee in a stage 3 patient. And you can see compared to a normal fat biopsy, it's just completely different. There is a hyperproliferation and hypertrophy of the adipocytes, you can see there. And there's a lot more fibrosis between the cells. So around those cell walls, the adipocyte walls, are very purple. They're fibrosed and scar tissue's built. So what happens is the adipocyte is trying to grow bigger, but unfortunately that fibrosis starves it. It gets hypoxia and it dies. And that's what's happening to the one in the middle. That little adipocyte is dying. And what's surrounding it, the purple, is a mass of macrophages coming in to deal with that inflammation. And if you turn your head upside down and look at that little fat cell from a different angle, it looks like it's got a crown on its head. And that's classic of lipedema, that it's got this crown-like structure. And all the purple fluid between the fat cells is very, very different from a normal biopsy. Now, what we do know is that it's very inflamed fat, and lymphedema gets inflamed and red, but lipedema gets very inflamed. And we know that the connective tissue markers CD4, CD90 and interleukin-6 are observed much more inflammation in lipedema, hence the pain, than lymphedema. And this has been shown this year, just literally hot off the press, by Al Gadban's study. And she found exactly the same thing. So you don't need to read all of that. It's just to show you she found exactly the same thing. But what you can see in this part of this slide is, if you look, that lipedema had far more CD68, much more inflamed than the obese tissue from when they studied it. So there was altered vasculature and inflammation. And Sarah Al-Gadban has basically come out and said she feels it's, again, primarily a vascular disorder with a secondary growth of this gynoid formation of subcutaneous adipose tissue. So it's totally different from obesity and much more of a vascular condition. And that's what we're starting to think now. We're not just seeing this as fat, we're seeing it as a vascular condition. It's more than fat. And she said that this adipocyte hypertrophy occurs independently of obesity. Really important. And whether obese or non-obese, adipose tissue that's very metabolically poor is a sign of this inflammation. And the only other time they've seen this increased dermal blood vessels has been in inflammatory skin conditions. So it's an inflammatory condition as well. Very, very interesting work she's done this year. So think vascular and think inflammation, not like normal obese fat. Because obese fat isn't inflamed. You can see there the normal fat that we're all used to seeing, that lovely yellow layer. But the lipedema fat, when we do operations on these women, looks completely different. You can see the fibrosis there between the layers. You can see the huge adipocytes. And in obesity, if you actually see hypertrophic adipocytes, they're actually markers of inflammation. It's a metabolically changed fat. And that's what Al Gadban talks about. Different to normal fat. So if I haven't convinced you by those slides, I don't think I will convince you that lipedema is different to normal fat. And we've known for quite a long time actually about this fluid within the fat. This is a beautiful slide that Karen Herbst, one of the endocrinologists in America, has allowed me to use, that shows this fluid within the fat cells. And this is from a paper in 1986. So on the left there you can see 5 little adipocytes, and in the middle of them you've got the capillary, and then you can see all the fluid around that capillary. And because you get this exudate and fibrosis, the basement membrane of that capillary on the picture B is thickened, so it's not working properly, and then it dilates and becomes like a little bit of varicosities in there, so dysfunction in that vascular system. So think about these ladies in the fat are just leaking fluid out into their fat all the time, causing pressure within their fatty tissue. And this is what it looks like on MRI. Beautiful pictures we've had published in 2009. On the left, showing all those little white dots with the arrows, they're fluid within the fat of that lipedema leg, and that looks like a stage 3 to me because it's got skin folds up at the knees. All right, but over on the right hand side, on picture B, that's showing the lymphatics. They're actually beautiful, lovely linear lymphatics you can see, apart from right down at the left of the ankle there's some tortuosity. So these people, until their lymphatics give up and fail at a later stage, have pretty normal lymphatics. It's a vascular disorder which actually overwhelms the lymphatics down the track. And Rachel Krasinski's done some beautiful work as well with MRI. And this is showing the fat and the fluid within the fat. So on the left we've got a healthy female, and on the right, the stage 1, early stage lipedema. And these ladies are quite difficult to diagnose. A lot of people say, oh, I don't know if it's just fat or if it's lipedema, because it's got more of a smooth surface of the skin. They're both of equal BMI, but look at the difference in the calf circumference. The fatty tissue is massively different on the lipedema stage 1 patient on the right. And you can see right the way through the hips and through down the legs to the knees and the calf, where they actually took the cross section there, much more fat on the lipedema stage 1. And they actually showed that in lipedema stage 1, the fat to water ratio was 3 times higher than on control on MRI. It's a trend in lipedema arms, but it's statistically significant in legs. There is more fluid in the fat. And obviously columnar legs and gravity fluid's going to build up more at the bottom, so that's why we see it more in the legs than the arms. Thank you to Rochelle for letting me use that slide. So this vicious circle builds up. We start in the top left hand corner. You've got a hyperproliferation of those adipocytes. They're inflamed with venous hypertension, and that overwhelms the lymphatics so that they're not as functioning as well. Then we get more and more tissue fluid building up until it eventually overwhelms the lymphatics. And these people then develop lymphoedema when the fluid leak from this venous incompetence overwhelms and the fibrosed adipose tissue compromises the lymphatic vessels so much they fail. And once you get lymphedema, there's even more inflammation and fibrosis. And we know that with lymphedema, if you put lymphatic fluid next to fat precursor cells in the Petri dish, they grow like crazy. So then you have even more hyperproliferation of adipocytes, and this vicious circle goes round and round and round. And it's our job to recognise lipedema early and nip this in the bud and stop this vicious circle as much as we can, as quick as we can, to stop progression of the disease. Because legs come in all shapes and sizes with lipedema. And what we used to not know was, why do some women progress to these later stages, like the bottom middle picture, quicker than others? And why do some people never get to that stage 3? Why do some women stay with the smaller legs with the nodular fat? And why do some get lipolymphedema and others don't? And we've got the answer now, okay, which is great, which is hypermobility. Karen Herbst has found that 60% of lipedema sufferers have hypermobility. You can see there on the listing on the right, there's more and more patients with the later stages have hypermobility. And what we think is that there's a link to Ehlers-Danlos syndrome, and that their connective tissue is able to stretch more with hypermobility for those women. So therefore those fat cells, as they grow, just stretch that tissue out and they get bigger and bigger. And also with hypermobility, the vascular system's affected and it's more leaky. So these ladies are leaky ladies who get bigger and bigger, and then that fluid is stimulating the fat cells more and more and more. So we've got to identify these women out of lipedema to really be good with their treatment. So what we know about stage 1 to 2 progression is its age, its inflammation, and obesity obviously compromises the lymphatics. But that development from stage 2 to stage 3 is that they get more and more fibrosis in the tissues, and also connective tissue disorders, the hypermobility, as well as the age and obesity makes them progress. Now, also what we know with once you get to stage 3 with those big fat folds is that it's very different to move around when you've got a body like that, so that the energy expenditure really, really reduces. And also changes in metabolism. A lot of these ladies go to starvation levels to try and reduce their body size, and that has a big change on their metabolism as well, worsening the situation. So for those GPs out there, or anyone who, you're not going to be able to totally treat lipedema after listening to this webinar, but how would you go about asking some questions if a patient walks in to see you and you think, hang on a minute, I think this woman's got this syndrome? The first thing is you're going to ask for their history, and a lot of them have got a long story to tell you about what happened in puberty, menopause, whether they've had any gynecological surgery or pregnancy, and whether their body changed rapidly at those times. They do have big stories because they've been disbelieved a lot, and Stutz has found that it takes a patient an average of 4 to 30 years to actually get diagnosed, and that they have a family history of these swollen, thick legs, columnar legs in the female side of their families, the worsening in the heat and the orthostasis, and ask them if the hands and feet swell. If definitely not, probably lipedema, but if they do, it could be pure lymphedema, or they could have the lipolymphedema. And ask them about calorie restriction and exercise and disproportionate weight loss. And ask them about pain in the fat and bruising easily. Like I say, many are malnourished or have eating disorders, so a lot of them are very psychologically damaged and may need intervention. And they may take a long time when you ask them their subjective history. Objectively, what you're going to look at is their stance and their gait. If they're hypermobile and if they've got big legs, they get valgus knees and also pronated valgus feet. So big problems with knee pain, hip pain and ankle pain. So you know the minute you undress this woman, have a look at her, what the main complaint I have is that no one looked at them. They asked them a few questions, but nobody ever looked at their fat. And to really diagnose lipedema appropriately, you have to strip the patient down to their underwear to see everything and to be able to see and feel the fat. So please get your patient undressed. A lot of them say, you're the first person who's ever undressed me and looked at me properly. You're looking for that symmetry in their fat distribution. The fat looks like a mattress with bumps in it, and there's skin folds in the big cases. The disproportion of it, is it columnar? Is it saddlebags? Do they have arm involvement? Is there abdomen fat or not? You're looking for varicose veins, which are very common, reticular veins, telangiectasia or spider veins, and bruises. We do Stemmer's sign, and that's the ability to pinch the skin between the second and third finger or the second and third toe. And if you do that on yourself now, pinch yourself between your second and third finger and just try and lift the skin up, and it should lift up really normally. If you've got lymphedema, you wouldn't be able to do that. So you would be Stemmer's negative on the hands and feet. And then you've actually got to feel the adipose tissue, because it feels like a beanie boo. For those of you who've got kids like me and they've got beanie boos or bean bags, there's a polystyrene type of nodular fat, and sometimes it's as big as peas. There's bumpy mattress skin texture, and the palpation, you're looking for pain, and we've already talked about the pitting test. I pinch them, I gently palpate them and see what kind of pain they've got. And look for any large nodules or lipomas. You can get large walnut-sized, grapefruit-sized lipomas on the lipedema legs, but what lipedema doesn't have is anything on their back or abdomen. That's more of a Derkham's disease, which is another fat disorder. So normally I get ladies to say, look at the skin on your legs, look how nodular that is, and lumps and bumps, but feel your tummy, how soft that is and how different it is. That's the difference between lipedema fat. You're going to do Baton's scale, and I'll run through this very, very quickly. It's can you now or could you ever? I normally say the first thing is can you touch the floor, and the women normally can palm the floor really easily or stretch their fingers back, and you get certain points. I'll not go into that now because you can look that up, but you can do a very quick Baton's scale to see if they're hypermobile. And basically you score them out of 9. Pre-puberty, to be positive for hypermobile, you need 6+. Anybody up to 55+, and the over 50s 4 is the diagnostic threshold as we stiffen up with age. So you can see if they're hypermobile, and then to educate them that they're likely to get worse, and we need to deal with this. Now, objectively, I do a lot more. You guys won't have what's called a pyrometer on the right-hand side. I'm very lucky to have a scanning machine, a pyrometer, to scan the legs for size, to look for change with treatment. And I use tape measures, but you guys can use a tape measure and do their waist-hip ratio. And to be diagnostic truly for lipedema, the waist-hip ratio is less than 0.7. Okay, it's not so helpful if there's concurrent obesity, but it's something that I really encourage them to lose some weight around their abdomen if they've developed obesity as well, so we can revisit that and see if it's truly a lipedema. Be aware, I have got ladies around their hips that measure 2 meters. I've got a lot of ladies who are 150+, so it's embarrassment if your tape measure doesn't go all the way around. Make sure you've got a big tape measure in your practice. And like I say, I use pyrometry, and I use limb circumferences, and I'm very, very lucky to have the little Delphin moisture meter that gives me percentage tissue fluid to look for edema. That scans the body. It won't look for fluid in the fat, but certainly it looks for it in the skin. Now, differential diagnosis. Not every cuffed or columnar leg or arm is lipedema. The lady on the right of the writing there, that lady's got lymphedema, but she's got a cuff around the ankle. She's got huge swollen feet as well. The ladies on the bottom have all got some lipedema. A lot of people look at the lady in the orange t-shirt second along and say, really? She's so skinny. I wish I'd taken a picture of her with her t-shirt off. She's got a tiny waist, and she's worked and worked and worked her body in the gym to try and get rid of these columnar legs. So you can see her legs are very columnar. You can see it's like cellulite on steroids around her bottom, and that goes right the way down her legs. And the closer picture of her ankles, which is the next picture along, you can see she's got no definition for a thin woman around her ankles at all. She hasn't got the cuff, but she's got none of that definition there at all, and she's got nodular fat all the way down her legs. So she's a stage 1 lipedema. The lady on the far right is very worried about getting lipedema. Her mother has it. She's a very thin lady and she's suddenly developed some saddlebags. So we're monitoring her. I'm not sure if she has or not. And the lady before her has clearly got dimpled fat, lots of reticular veins around her knees, but she's got obesity as well. So she's one of the ladies I've said, you might be a bit more of a mixed picture. I'm not going to label it yet, but we need to go away and lose that tummy before we actually label it. It may be just obesity. So lots of different dimpled legs come and see me. And gynoid obesity, I see a lot of ladies culturally, especially Middle Eastern, Greek ladies, Italian ladies come in, and there's a propensity for laying down fat around the bottom area. So we've got to differentiate between that. Now, one of the differential diagnoses is lipohypertrophy. Now, these people have a disproportionate body shape, symmetrical increased adiposity, and the extremities are unaffected. And they're resistant to calorie restriction and exercise, but they do not have any bloating or change, swelling with standing still, sitting still, or heat. So these are the big changes. There's no bruising with these people. And pain and sensitivity is not an issue in lipohypertrophy at all. But a lot of these ladies are seeing lipedema pictures online and joining Facebook groups and defining themselves as lipedema when they don't actually have it. And that's important that they don't do that, because lymphatic treatment has no help. They're wasting their time coming to see me because there's no fluid to lose. There's liposuction if they want a cosmetic effect. But what we're wondering at the moment is true lipedema preceded by lipohypertrophy, and therefore should we be putting compression onto these women to stop progression? I don't know the answer to that yet, but it's a watch this space. But there's a lot of people who just have lipohypertrophy and a tendency to develop fat in certain areas that's not so nodular. A very extreme picture here of android obesity. That gentleman has got a belly and a half, and a very extreme picture of gynoid obesity around the bottom only. But these people can come in as well wondering if they've got lipedema. Obviously with our obesity patients, proportionate adiposity is central. It's not down the legs, no bruising, no painful fat. Now these people may swell because those tummies will compromise their vascular system through the groin, and so they can get lymphedema in the legs down the track. We get a lot of people now, big obese people, getting lymphedema secondary to obesity, and obviously it's a very dangerous situation, so we need them to lose that fat. The problem we've got is lipedema patients can have obesity as well. Many of patients, 50 to 80%. So they're the people I'm really working with to try and get them to lose weight, to get a true diagnosis, and to make sure they don't get lymphedema secondary to obesity, which will really make their lipedema go crazy. You guys will see a lot of this through in the community. This picture shows that there's a lot of different reasons metabolically why people can get fat more up the top of their body, so upper arms, upper thighs. And these are the people we need to differentiate between the type 1 saddlebag type of lipedema, the love handle high insulin fat, the butt, hips, thigh fat from estrogen, progesterone, and insulin resistance as well. And this is a lot of my work, is working with people to make sure that I'm not treating them, but they're back in the community losing weight and getting their insulin resistance sorted out. So I send all my clients for blood tests for differential diagnosis, and I don't think GPs like me very much because I send them for this massive blood screen and many come back normal. but we should always check them. We don't want to miss an underlying hormone, thyroid or adrenal liver function problem that they should go and see an endocrinologist before, and that's reversible in many cases. I actually get them to get their ESR CRP checked for inflammation as well, and fasting blood glucose and HbA1c, looking at diabetes insulin resistance. And if you want to get the list of what I use Karen Herbst, the endocrinologist in America's list of blood tests, and that's on her homepage, lipomadoc.org. It's fantastic. And I send people off to get this huge screen. This is a brilliant resource that if you're interested in this talk and you want to be able to differentially diagnose lipedema at a later date, you can get online. It's from the Fat Disorders Research Society. It's a brilliant check sheet to work through the differences between lipedema, lymphedema, obesity, the lipolymphedema and pure vein problems. And I'm not going to go through that now. We've talked about it a lot already, but it's a fantastic resource to print out. Please do it. It's great to have around the clinics. So this patient's come into you and you're thinking, this person has got the subjective history, they've got the objective signs, and I've screened their blood. Well, now what do I do? And basically, you've got to find somebody like me, a qualified lymphedema practitioner. And luckily, we have a National Lymphedema Practitioner Register, which is known as the NLPR. That's the web link for it through the Australasian Lymphology Association. And the people who are listed have to re-register every year with accredited CPD points. They work in both public and private settings. And many of the practitioners on that list are physiotherapists and occupational therapists, so that you can use a chronic disease management plan from Medicare to help patients if they do need to go into a private setting to see someone. You'll need to refer to other multidisciplinary team members as well, depending on the woman's situation. A lot of them need some psychological support. Dietitians, and I'm going to talk about diet in a moment. So we're looking for dietitians who support low carb and ketogenic eating, anti-inflammatory. Low fat eating does not work for these women. OTs for the bigger ladies may need adaptations and mobility aids. A podiatrist if they can't reach their feet. Wound specialists for women in the later stages, and footwear specialists. And a lot may need an endocrinologist or a pain specialist or a district nurse to come out and see them. Because the treatment that we do is it's holistic, it's comprehensive, it's multifactorial. We're managing pain, we're reducing inflammation, we're improving lymphatic flow, we're emotionally supporting the woman, and we're helping them deal with the lipedema and get fitter. And a lot of those goals overlap in the middle. And the biggest one that overlaps is exercise, which I'm going to talk you through in a minute. We also need to prevent and treat obesity using diet and exercise. We're treating the fibrosis and improving the lymphatic flow with compression, sometimes with manual lymphatic drainage massage if the tissues are congested and we need to get rid of some edema. So I'm going to go through all of these components of their treatment individually now, because that's Karen Herbst. She has come forward and said exercise in combination with diet is the cornerstone of treatment to lessen severity of symptoms and slow down progression. And the other person who's been promoting treatment of lipedema is Tobias Birch from Germany, and he said that we need to stabilize this condition and exercise them is the priority. So exercise is the first thing I'm going to talk about. And big ladies can exercise. And I don't always talk about exercise. I put that in brackets because a lot of the big ladies, if you talk to them about exercise, they'll look at you and just, you can see in their eyes, they think, how do I exercise with a body like this? And basically I ask them to move as much as possible, wearing the compression that we prescribe for them. To be aware that intense exercise, so running, spin classes, heavy weight training, can increase that tissue hypoxia, and the fat cells can get more inflamed because of that. So we're looking for low impact and something pleasurable that they're going to stick to. So things like swimming, water aerobics, walking, getting on the bike, tai chi, getting on the elliptical trainers that take the pressure off their joints, doing some Pilates, dancing around their kitchen with the grandkids, or getting a personal trainer if they need some motivation. It's got to be what they are actually going to do and love, otherwise they'll stop doing it. Tailored to their needs. So the big ladies, my favourite thing is to say, yeah, you can sit and watch TV, but get some of the $39 recumbent pedals from Kmart, and you can pedal while you're sitting on your sofa. They can do arm weights if they can't move the bottom of their body because of pain. And we want to, if they're hypermobile, prioritise strength to support their joints. And if the yoga and the stretching elements are only for those who don't have hypermobile. Those hypermobile ladies do not need any more flexibility. So I encourage yoga and stretching only for the my non-bendy ladies. And like I've said, I use the words movement activity, and really encourage hydrotherapy for those later stage clients, because in the water, if you can get deep in water and exercise, even just walking, the buoyancy of the water will give an up thrust to the body and take some of that body weight off the joints, and ladies can suddenly move when they can't move on land. The other joy of hydrotherapy is if you're into neck deep water, that you actually get a 30 to 40 millimeters of pressure around the ankle, and that's higher than most of the compression garments that these ladies wear. So you get that extra pressure to relieve fluid from the lower legs and help the lymphatic system. If they've got valgus knees and foot problems, orthotics are really, really important to line them up and take the pressure off the joints and then strengthen them up. And to be aware that with any patient who has got big legs from fluid, fat, whatever, a shuffling gait or Trendelenburg gait where they waddle side to side due to either fat, the malalignment that the fat gives, and they can't walk properly, there is a massive reduction of calf pump. And that calf pump is the major thing that reduces the edema for you and I. So the biggest thing you can say to your patient who's got a lot of edema is try and walk heel to toe to get that calf pumping. It makes a massive difference. Compression. A lot of people think compression is really, really daggy. And you can see from that picture of a lipedema lady, she's wearing some pretty funky compression on her legs. So ladies can feel good about their legs again. We're doing it to increase the lymphatic flow, to reduce the leak of the capillaries, to assist with their varicose vein management, and it reduces that heaviness and pain when you've got vein leakage going on and capillary leakage in the fat. So that's how I sell compression to these women, is your pain will be reduced, the heavy feelings in your legs will be reduced. And it supports those tissues. So it squeezes the tissues into the bone. So for those hypermobile ladies where their tissues are hanging, sagging off the bone because of stretchy tissue, we can push it back in towards the bone and reduce the size of the legs and actually improve mobility in those later stage ladies just by compressing everything back and letting them walk better. It may help prevent lipedema progression. If you stop the leak, you stop the stimulation of the fat cells, but they have to fit. And unfortunately, due to the size of the legs and the folds of the legs, they frequently need to be the really expensive custom-made garments. And if somebody comes into your practice and says, oh, I've been given compression, but I can't wear it, it hurts, I hate it, it's painful, they're not in the right compression. Some correct compression will be comfortable, so with the thicker materials that don't pull into the joints and crease into the folds and cause constriction pain, the proper materials that have been properly fitted should be comfortable. They should be not joyous to wear, but easy to wear. And if people can't reach their feet to actually get them on, we've got aids and adaptations. So if that's the barrier, if somebody says, oh yeah, I've been given compression, but I don't wear it, I can't get it on, tell them to go back to a therapist, because we can get them things to help them. And sometimes we have to layer garments to help promote independence and compliance. So this beautiful slide is from Katja Schoenweiss from Job, that shows that most ladies with lipedema need to wear the one on the left, the garment that goes up to the waist, the pantyhose, but many women can't get it on. So what we do, and she's used beautiful coloured garments to show this on the right, is either we get what's a thigh high, so the burgundy one goes up to the thigh on that lady, and then she's got a Bermuda short one to layer over the top to make sure she can actually get them on easier. Another option is you can have a knee high, so that the third slide along, the grey brown one, is a knee high, and then she's layered that with a capri style one so she can get them on easier. More expensive to do that, but it's no use buying a $400 garment on the left and not wear it. You're paying a bit more for the ones on the right, but they are more likely to be worn and therefore be cost effective. For those that really can't manage a garment, wraps are on the market as well for lymphedema and lipedema that wrap round and are easier to get on and off, and they adapt to size better. So if somebody needs bandaging, they're far more cost effective, and if someone's size is going to rapidly change due to surgery, they're a very good option because you can get them on easier and you can layer them as well. So a lot of my ladies, again, if they can't cope with the thicker garments that you've just seen, will wear a light compression pantyhose underneath, more like a sports compression. And for those leaky bits right at the bottom, where the fluid builds up, they're using compression wraps on the bottom part of their leg, which they can get on over the top easier. A bit like the middle picture there, you can see it's got a lightweight compression in white with wraps over the top. Skincare is not such a problem as lymphedema. We still promote using emollients. We rarely see cellulitis. We rarely get wounds unless they're in stage 4, but we get fungal infections in the skin folds. And their foot care for those who can't reach their feet. Foot care can be a bit of a problem with dry skin build-up, but generally skin care isn't much of an issue with these ladies. They've normally got lovely smooth skin. For those with edema, we do manual lymphatic drainage massage, or we can use these devices that you can see on the left. They're lymphatic pumps that move mechanically the fluid. And I really like, if someone's having regular lymphatic drainage, I actually tell them it's more cost effective over time. Rather than coming to see me once a week or once a month for a massage that's not going to last very long, they'd be better going in a pump every day at home and paying for that. Tobias Birch has said, in the early stages when there's not a lot of fluid build-up, there's no basis for this weekly massage. And on the internet it said you must have regular MLD, and he debates that that's not true. If they're in good compression and looking after their vascular leak themselves, they shouldn't need that. MLD, manual lymphatic drainage massage, is only for those with orthostatic edema in the later stages and probably when pumps are not helpful. Or some of the patients come and see me in the hot months for a bit of extra help, and certainly where you guys are in North Queensland, you may need to use manual lymphatic drainage more. And for times of exacerbation, I really do push self-management with pumps at home. Now, nutrition. This is probably the most confusing thing for patients, because online there's every diet known to man on there is said to be useful for lipedema. And this is the main thing my patients will come and talk to me about, is online. I've seen all of this and I have got no idea what I should be doing. I'm really confused. What we do know is that nutrition is absolutely vital. There's no major research in this area as yet, but anecdotally it's the ketogenic diet and the low carb seem to work best. And some of the women doing a Mediterranean and an anti-inflammatory sort of diet, it works best. There's a special diet out there that Karen Herbst has devised called the RAD diet, the Rare Adipose Disorders diet, but it's quite restrictive. It doesn't have any meat or dairy in it, and very simple, and it's low carb as well. It's quite restrictive, and it's got a low FODMAP basis to it, as many ladies do have sensitivities to food, but I find that women generally can't stick to that, and I think that's why the low carb and ketogenic is working best for them. We've got to remember all lipedema patients have different issues, and as yet there's not one way of eating that suits everybody. So what we try and encourage is to reduce inflammation and lymphatic load with diet. So diet we know is critical to influence the fat but we don't know what it does to the nodules. But what my patients certainly say, the ones that do low carb and reduce their processed foods with low carb or either Mediterranean eating, is that their nodules don't feel as hard and sore when they do that, taking the inflammation away. I've already talked about that there's no one better than others, and basically it's a bit of individualized trial and error. But we need to tackle obesity early to stop the lymphatic overload that a big tummy provides, and prevent future weight gain as well, which will make their lipedema a lot worse. Now, one thing I do promote is avoiding long chain fatty acids, which are generally in processed foods and dairy, because we know that the gut doesn't absorb long chain fatty acids through the mesentery. It goes through the lymphatics. The mesenteric lymphatics pick up long chain fatty acids. So we don't want the mesenteric lymphatics choked up with long chain fatty acids from processed foods. And this is maybe why avoiding processed food really works for these women, as it can increase your lymphatic load by 6 litres a day if there's lots of long chain fatty acids there. Increase omega-3 to reduce inflammation, but really it's down to low carb because of metabolism. We know that lipedema patients are metabolically challenged. Some of my ladies are living off lettuce leaves and not a lot else, and they're still putting weight on. Some have virtually got, like I say, no metabolism, and when I've sent them off to see Joe Proietto, the obesity specialist and endocrinologist here in Melbourne, he is absolutely fascinated by the lack of metabolism in these women. Remember when we talked about the genetic slides, that lots of the genes are linked to the thyroid? Maybe this is the link to metabolism in these women being so poor. And the majority of my lipedema clients seem to come in and say, you know, I was managing this condition. I didn't like my legs, but it was manageable. But when I hit the perimenopause or the menopause, and that estrogen effect and the change in metabolism around menopause, my lipedema seemed to go berserk, and suddenly I'm developing a tummy for the first time in my life, and dieting is not reducing the tummy, and I see a lot of that. And what we don't know is if the genetics and the pathophysiology of lipedema predisposes to weight gain, or does the weight gain predispose towards lipedema where they're genetically susceptible. We don't know that yet. But what we do know, and this is Karen Herb's slide, is that lipedema ladies generally don't get diabetes. You can see here in her study there was only one diabetic woman and she had stage 3. But more interestingly, underneath that red line is pre-diabetes. And what we can see and what we know is that pre-diabetes increases as the stage increases. You can see there 30% of women were found to be pre-diabetic and insulin resistant in stage 3. And Sarah Al-Gadban's paper that was released this year, 3 of her participants had pre-diabetes, non-diabetes, but none of her controls in the obese patients had pre-diabetes or diabetes. So is that why central adiposity starts in lipedema women? And is that why low carb and keto works so well for them? Because we're just taking that carbohydrate away. And we're not sure yet, but we think from the genetic slides, again, there was a few with insulin sensitivity, that lipedema ladies may be genetically more predisposed to insulin resistance and obesity. Now, you may not know a lot about ketogenics, and I find that a lot of GPs are very frightened of the keto diet, but more and more we're finding out in the lymphatic world that there's a role. We think ketones actually improve lymph vessel growth, and there's a role for ketogenic therapies in lymphedema. These are brand new papers, July this year. So keto is becoming a big thing in lymphedema and lipedema, looking at it, and it's safe to do if it's done correctly. So I tell my patients, I'm not a dietitian, I can't teach them, but I use the Low Carb Down Under website to find doctors and dietitians who will support my patient safely with blood screening through a ketogenic way of eating a low carb, high fat diet. So that's how I do it safely for my patients. And after 24 months, does it really matter? Eric Westman from the States, this is his slide that shows the red's the low-fat diet, and we find that weight plummets on a low-fat diet in the first couple of months, but then everybody regains it because they're hungry and they're not, there's no satiety with it because it's all carbohydrate based. The Mediterranean diet, you can see, drops off again, and then it's more sustainable with more weight loss. And the low carbs, the blue, you have a massive reduction. And what happens is they do tend to regain because it's restrictive. So that's why they regain and come out the same at the end. So what I say to ladies is, look, start with a less processed food Mediterranean way of eating first. And if you're not losing weight, I tend to tell them that you can do low carb, try it for a period of time to try and get a bit more weight off, but then stabilize again by going back to the Mediterranean way of eating with lower carbohydrate. Now, very quickly to finish, I'm going to give you a little bit about liposuction. So I was really lucky enough 2 years ago to go into surgery with Mr. Cheyenne in Melbourne, and that's the aspirate of what he got off one of the ladies that day. And it doesn't look like the fat that comes out of normal fatty liposuction. You can see it almost looks like it's got fatty plastic chunks in there because the Lipoedema fat is far more fibrosed and tenacious, and it was amazing to see the difference being in theatre with him. Everybody acknowledges that the first step of managing lipedema is what we've just discussed, conservative therapy, but liposuction may be necessary for those in significant pain. They can't walk, their gait's altered, a lot of joint pain, to allow function. And what I will say is, if your patient is considering surgery, research it. Get them online, get them to research their surgeon, join a Facebook group and hear from other patients around Australia and the world who've had it, because they need to choose the right surgeon and technique for their needs. There's not one way of doing this, and it needs to be right for the patient. Because it differs from cosmetic liposuction, they don't want to damage the lymphatic system, so they have to choose the surgeon experienced in liposuction for lipedema to make sure there's no disruption to their lymphatics. That's critical. Now, this is one of my ladies who had surgery with Mr. Cheyenne last year, and you can see she's got a huge scar down that inner right thigh. She's gone on and had her left leg done. But that's a 50-year-old woman who came in on a walker. She's now ditched a walker. She can do stairs by herself. Amazing the amount of fat. He got 12 litres of fat off that right leg. And it's not a cosmetic procedure. Because so much comes off, the skin would just be hanging down. They need to do a skin lift. And that lady doesn't care. She's got 2 scars down the middle of her legs. It was a mobility salvaging procedure for her, and it's given her her life back. So the types of liposuction they do, we're going to discuss water assisted, power assisted, and tumescent. So the tumescent is before they even put the cannula in to do the liposuction to protect the lymphatics. They put cannula in, microcannula, and they infiltrate massive amount of fluid with local anaesthesia in, and basically blow those legs up very, very turgid like a watermelon. And then they can put their cannula in and take the fat out, because the lymphatics have been moved away from that fatty layer by putting the fluid in. And they either, with the picture at the bottom on the left, water assisted is like putting a pressure jet in there and the water blasts the fat cells out. And the power assisted on the right is more like a jackhammer, and it jackhammers them out. Mr. Cheyenne uses the power assisted. He doesn't believe that you should be putting more water into an already fluid overloaded woman. Others believe in the water assisted one. So there's different ways of doing it. It's safe. It significantly reduces the pain, the bruising, their movement's better, their gait's better. Cosmetically, the women love their legs, even though they don't look that great cosmetically afterwards. Sometimes they're lumpy and bumpy in texture still afterwards, but the women love the improved quality of life they get and their self-esteem. And their normalised body proportions are massive to them. They love it. And Schmeller, the German surgeon, found that 23% of women could omit a lot of their conservative therapy. They could get rid of having this regular MLD or go much longer intervals to having it. So it doesn't cure the lipedema. You can't cure a genetic problem with surgery, but it can really help to omit the therapy as well. Give them some more time for themselves, rather than a lot of lipedema ladies, their life is completely about the lipedema. So those are the safe procedure is being looked at in a lot of studies now. What you do need to be aware is liposuction is now being chosen by those in stage 1 a lot to try and prevent the disease progression. The earlier stage women are going to have the nodules removed so that they can't become hypertrophic and get bigger and bigger and bigger. So they're trying to use it to prevent them getting to stage 3 now as well. So these are our surgeons in Australia. That's Ramin Cheyenne at the top, and he trained under Dr. Stutz. He's based in Melbourne, which is why I've got a big association with him, being Melbourne based myself. Naveen Samaya, lovely man I've met when I've been at conferences through at Sydney, and he trained about the same time with Dr. Stutz. Thomas Lam from Sydney trained under Bråsen, who's Swedish. And the new kid on the block is Chris Lekich, who's up in Queensland on the Gold Coast, and he trained late 2017 under Dr. Heck, one of the German doctors. Now, very, very busy slide, but this basically shows that what each of them do. Mr. Cheyenne uses the power assisted, and he does the one full leg at the time. And you'll need multiple surgeries to do those legs and take all the fat away, and he will do arms and abdomen where required. Mr. Cheyenne does the biggest of the biggest women. He doesn't have a maximum BMI because he is the one that will remove skin. So they do need an inpatient stay, and he works with the therapist to give an individualized compression approach. He's also very careful. He uses indocyanine green and patent blue imaging to avoid the lymphatics. And being a microsurgeon, plastic surgeon, he can do a lymphovenous anastomosis for those who've got lymphoedema as well. The next person is Thomas Lam, and he does one leg at a time, full leg with tumescence, but he only takes a BMI up to 32 because he uses class 2 compression garments for 2 years, 24 hours a day for 3 months to tighten the skin up, and really works on long-term weight control as well. Dr. Lekich does the wall, the water-assisted technique, and he does the surgery, both the lower legs first, then both upper legs 6 weeks later, then a tidy up of both legs, and then the arms last. He doesn't do a skin lift, and the big thing to know about Dr. Lekich is he does it under twilight anesthesia as a day surgery, and when you have water-assisted liposuction, the holes are left open so that the fluid flows out afterwards. So the women have to be aware that they're going to see a lot of bloody water coming out of their legs. They have to stay next to the hospital in a hotel with plastic sheets on the bed, and when they shower, all this water is going to run out the legs. So if they're squeamish, this is not the procedure for them. He does do vein surgery, and he will do ultrasound scans of the veins and treat any underlying venous problems at the same time. Mr. Samaya in Sydney does the wall technique, and again, he does the thighs first, the lower legs second, 3 months apart, and he does take BMIs up to 40, but doesn't do a skin lift. Ramin's the one who does the massive legs with the skin lift. And he's very good on his conservative therapy there that I won't go through. So that's what our Australian surgeons are doing. So in conclusion, lipedema is very complex, and there's likely many phenotypes of it. We need to think of it as a vascular and an adipose disorder with inflammation and tissue fibrosis. It's more than just persistent fat. And if we can control the fluid in the fat, we may be able to control the fat better. And lipedema and obesity are two different diseases but can appear together, so we need to tackle both, with giving patients a concept of stabilisation and prevention, and hopefully now you've been educated, earlier intervention with people like me. There's no recipes, it's individualised collaborative care, and it's essential that we treat them with the multidisciplinary team and holistically. So on that note, I'm going to start taking some of the questions. I can't see them yet, that's why I haven't been answering them as I've gone along. I'm going to have a look now and see what hasn't been answered. But as you can see all around the final questions there's lots and lots of resources for women and for yourselves. I can really encourage you to look at Lipoedema Foundation. It's got some great stuff for health professionals on. And the Lipoedema Australia conference next year is going to be in Sydney, so I'll give that a plug as well. It's fantastic, where you can come and meet people like me who love treating lipedema and all the surgeons and learn a little bit more if you're interested, and meet some of the women as well. So if I come out of my screen now.
So there's no questions in the conversation panel, but does anybody have any questions for Helen?
I've blown the minds, Kayla. It's quite a lot to take in an hour.
So there's one in there, does lipedema treatment tend to be supported through public hospitals?
Okay, varies. This is where I'm a bit hazy for Queensland, but certainly in Melbourne, the Mercy Hospital will take lipedema patients, but I know increasingly they field them out to more specialists like me out in the community. But that would be something you'd have to look into. Your best resource for Queensland would be the Royal Women's in Brisbane, Leonie Naumann, and Hildegard Ruhl-Hirsch are the big therapists there. They're very experienced, and they'd be able to tell you what their local criteria is at Brisbane and give you a better understanding for North Queensland, where your centres are to send these people. The best way as well would be to go on the National Lymphoedema Practitioner Register and you type your postcode in. And for you up in North Queensland, far North Queensland especially, I would do at least 100 Ks around that area. So you put your postcode in and then select 5Ks, 10, etc. I'd put at least 100. And if you're incredibly rural, put up to 500, and you'll be able to see which lymphedema practitioners are around. They'll all have a basic understanding of lipedema, but some of them on their websites would be able to tell you if they're a specialist like me who does a lot of lipedema work, or is working at a higher level. I'm about to embark on my PhD in lipedema, so I'm pretty interested in this condition. Any other questions?
Hi, Helen. My name's Julie. I have a question.
Go for it, Julie.
I'm just wondering, I have lipolymphedema. And I'm wondering if the far infrared sauna therapy is good for that, because I have a far infrared sauna. I've heard it's good for lipedema, but not good for lymphedema.
Yeah, if you've got lipolymphedema, we don't encourage saunas for lymphedema because the heat will definitely make your blood vessels dilate. So your veins will dilate, your capillaries will dilate, and they will leak more fluid out. So especially for lipolymphedema, where a lot of ladies, especially if you're hypermobile, if you're very bendy, you'll be one of those really leaky ladies. We don't recommend it because you're going to dilate those blood vessels. They're going to leak more fluid out into the tissues and worsen the edema component of your condition. So I would say for you, definite no. A cooler spa would be better for you rather than an infrared sauna. So if you've got a mild spa and it's not too hot, obviously you're in far North Queensland, so you probably have your spa cooler. That would be better for you to get in.
All right, thank you, Helen.
No worries.
Is there any other questions? No, we might wrap it up there, Helen.
No drama.
Great. Thank you so much, and thank you everybody for attending.